Hello, everyone. Welcome to.
Wait, that's my line. Hello, everyone. Welcome back to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm your host, Majd Hakki, and today we're here to walk you through MSK trauma. I'm joined by the second best football player in the Hakki family, my brother Beshr.
First of all, I'm the better player.
Is that why you made me do all your campaigning videos?
Anyways, I'm Beshr. Think of today's episode as a structured crash course through upper extremity and lower limb trauma, fractures, joint and ligament injuries, bone pain, arthralgia, and neuromuscular injury.
So settle in with your coffee, Anki deck, or whatever you live on, and let's start with a classic high energy, lower limb trauma case. Alright, picture this. You're on call in the ER. It's loud, chaotic, and you've barely had your coffee. Suddenly, emergency medical service rolls in a 34-year-old man from a high-speed motor vehicle accident. He's awake, talking, vitals stable for now, but he keeps saying, I can't stand. My hip and thigh are killing me.
You get the x-rays and they show something you should always take seriously. A femoral shaft fracture and a femoral neck fracture on the same side. That combination tells you one thing immediately. This was a high energy injury. And when the mechanism is that intense, you never focus on just the bone. You think bigger.
Right, because injuries like this don't happen politely in isolation. This is the kind of pattern you see in polytrauma, where the impact is strong enough to injure multiple structures at once. They occur with soft tissue damage, blood loss, and sometimes pelvic injuries, hiding in the background.
And that femoral neck fracture? That's the part that should make you slow down. The blood supply to the femoral head runs right along that area. Disrupt it, and the bone can lose its oxygen supply. That's what leads to avascular necrosis, basically the bone dying from the inside.
So this isn't a slap a cast on it situation. This is urgent orthopedic planning, often with a CT scan to understand the neck fracture in more detail. Meanwhile, you're keeping an eye out for something sneaky, internal bleeding. A femur and pelvis can hide a surprising amount of blood before vitals start to show it.
And that sets the tone for today. Musculoskeletal injuries aren't about memorizing bones. They're about thinking through mechanism, the surrounding tissue, and the real-life consequences that follow.
Before we zoom in into specific regions of the body, we need to build a common language. Everyone's heard the words fracture and dislocation. But in real trauma settings, those words mean more than just broken or not broken. So let's break it down.
Let's start simple. A fracture is just a break in the bone, yes, but bones don't break in isolation. They're wrapped in muscle, vessels, nerves, periosteum, so any fracture comes with swelling, bruising, and some degree of soft tissue injury. A dislocation is when the joint surface loses their normal relationship. The bones that should be sitting face to face aren't, which almost always means ligaments and the joint capsule have taken a hit too.
And then there's the brutal combo, the fracture dislocation. That's when the bone is broken and the joint is out of place. Those are the ones you're fixing two problems at once, the pieces of the bone and the alignment of the joint. One classification we absolutely can't ignore is whether the fracture is open or closed.
A closed fracture means the skin is intact, no connection between the break and the outside world. An open fracture is any break where the bone communicates with the environment. Even a tiny puncture wound right over the fracture counts. The problem is bacteria now have a doorway straight into the bone.
So with an open fracture, the priority is clear. Antibiotics early, washout and debridement, and stabilizing the bone. Not because the bone can't heal, but because a deep bone infection is a nightmare to deal with. Okay, let's talk about how we actually put bones back together. People hear ORIF, CRPP, external fixator, but unless you've stood in an operating room, these words are just alphabet soup.
ORIF stands for open reduction and internal fixation. Open means we make an incision. Reduction means we realign the bone fragments into the normal anatomy. Internal fixation means we hold them there, using plates, screws, and nails.
We tend to use ORIF when precision matters, especially around joints or in fractures that are too unstable to behave nicely in a cast.
Exactly. And when we talk about long bones like the femur or tibia, we often use intramedullary nail, a metal rod inside the bone canal that acts like an internal support beam. It lets the patient bear weight earlier and keeps the alignment strong.
Now walk us through CRPP, closed reduction and percutaneous pinning.
This one's elegant. We don't open the skin at all to line up the bone. That's a closed reduction. Using traction, gentle rotation, or pressure, the surgeon coaxes the bone fragments back into place by hand. Once the alignment looks good, thin metal pins are inserted through tiny skin punctures to hold everything still. No big incision, no soft tissue disruption.
And it shines in simple fractures and pediatric injuries because kids heal beautifully and don't need the heavy hardware adults need. Okay, now the intimidating one, external fixators, the metal frames outside the limb.
They look dramatic, but the idea is simple. You stabilize the bone without opening the fracture. Pins go into the bone, above the break and below the break. Those pins connect to an external frame. The frame holds everything aligned.
And the key reason to choose this method isn't style, it's safety.
Right. We use external fixation when the patient or soft tissue aren't ready for a long surgery. Massive swelling, open wounds, unstable vital signs, multiple injuries. An external fixator buys time. It keeps the limb safe until conditions improve and you can convert to a more definitive fixation.
You also see fracture descriptions like transverse, spiral, oblique, comminuted. They're not random. They tell you how the injury happened.
A transverse fracture runs straight across, usually from a direct blow or bending force. A spiral fracture wraps around the bone, classic twisting or torsion mechanism. An oblique fracture is diagonal, somewhere between the two. A comminuted fracture is shattered into several pieces, high energy trauma territory.
And kids get their own patterns because their bones bend before breaking.
Exactly. A green stick fracture is when one side snaps and the other side just bends. A buccal fracture is when the surface caves in slightly. Both heal incredibly well.
One more thing, the force matters as much as the fracture.
If someone fractures the femur from a trivial fall, something's wrong. Weak bone, maybe even a tumor. But if the mechanism is high speed or a fall from height, that force alone explains the injury. And higher energy always means more soft tissue damage hiding underneath.
Now let's talk urgency. Not all fractures demand the same tempo.
Some are true emergencies. Open fracture, compartment syndrome, loss of pulse or ischemic limb, unstable pelvic fractures with hemodynamic compromise, septic arthritis. Some need early surgery, ideally within 12 to 48 hours, elderly hip fractures, unstable ankle fractures, certain tibial fractures when soft tissue are ready. And others are urgent but can wait a few days. Some need early surgery, ideally within 12 to 48 hours, like elderly hip fractures, unstable ankle fractures, or certain tibial fractures once soft tissue are ready. And other are urgent but can wait a few days, like many plateau, distal radius, or humerus fractures, as long as the limb is safe.
So in trauma, timing isn't random. It's survival, blood flow, and soft tissue health. Let's move up to the upper limb. Picture a 20-year-old rugby player who lands hard on the shoulder. He comes in holding his arm close to his chest, and there's a visible bump along the collarbone.
That's a classic midshaft clavicle fracture. And there are two things your brain needs to check immediately. First, skin tenting, when the sharp bone fragment pushes right up under the skin, stretching until it's thin and shiny. The danger is that it can break through, turning a closed fracture into an open one. Second, the neurovascular structures underneath. The clavicle sits right above the brachial plexus and subclavian vessels. So if the trauma was high energy or the fracture is significantly displaced, you always check pulses and sensation.
Once those two things are ruled in or out, the treatment becomes straightforward. No tenting, no nerve or vessel concerns. A sling and follow-up is usually enough. But if the skin is threatened or there is any neurovascular issue, that's when you move toward urgent surgical fixation. Now let's follow the force down the arm to the proximal humerus, the part that forms the shoulder joint. These fractures look innocent until you try to treat them.
Exactly. The proximal humerus is surrounded by the rotator cuff muscles, each pulling in different directions. When this bone breaks, those muscles can pull the fragments apart unpredictably. And because this region forms the actual joint surface, even small steps, gaps, or malalignment can permanently affect shoulder motion.
So planning the repair isn't guesswork. A CT scan helps map out how many parts are broken, whether the joint surface is involved, and where the rotator cuff tendons attach.
And once you understand the puzzle, treatment usually involves open reduction and internal fixation, realigning the joint and restoring the relationship of the tuberosities so the rotator cuff can function. Shoulders do not forgive poor alignment. Even small irregularities can lead to stiffness, impingement, or early arthritis.
Let's shift from fractures to dislocations. The shoulder has the most mobility of any joint in the body and pays the price for it.
That mobility comes from a shallow socket and a big ball. Great for movement, not great for stability though. So the shoulder is the most commonly dislocated joint. Most dislocations are anterior, usually from a fall on an outstretched arm or a forced abduction external rotation position.
When the shoulder pops out, something usually tears along with it.
Right, the labrum. The fibrocartilage ring that deepens the socket often gets torn. Ligaments stretch, and sometimes the humeral head or glenoid surface gets dented. And once the soft tissue support is damaged, the shoulder becomes prone to future dislocations.
Different from a true shoulder dislocation is the acromioclavicular joint injury. The classic fall directly onto the top of the shoulder.
Here, the clavicle stays put while the acromion drops down, stressing or tearing the AC ligaments. Depending on how severe it is, the joint may widen slightly or the clavicle may appear to stick up. Many AC injuries do fine with resting and a sling, but high-grade tears sometimes need surgical reconstruction.
While we're still in the shoulder neighborhood, we can't ignore the rotator cuff.
The rotator cuff tendons keep the humeral head centered during motion. They can become irritated, inflamed, or torn, either from overuse or trauma. If the space under the acromion narrows, the tendons can get pinched. That's shoulder impingement.
And the biceps tendon gets dragged into this drama too.
The long head of the bicep runs through a tiny groove and inserts into the shoulder. It can become inflamed or even tear, especially in athletes or older adults. Together with cuff weakness or labral injury, it contributes to shoulder instability.
Moving down to the elbow, a deceptively simple hinge joint that actually has a lot going on.
You've got two major stabilizers, the lateral collateral ligament, or LCL, resisting varus forces, the medial collateral ligament, or MCL, resisting valgus forces. So if someone reports pain on the inner elbow when you apply a valgus force, you think MCL. Lateral pain with varus forces, LCL.
And the elbow is also famous for overuse injuries.
Exactly. Tennis elbow involves the extensor tendons at the lateral epicondyle. Golfer's elbow involves the flexor pronator tendons at the medial epicondyle. Both come from repetitive gripping, lifting, or forearm rotation.
And then you have the dramatic tears.
A distal bicep rupture happens when someone lifts something heavy and suddenly loses control, causing the tendon to tear off its insertion. They lose strong supination and elbow flexion strength. A tricep rupture is rarer but leads to difficulty extending the elbow. Both often need surgical repair in active individuals.
Now let's tie fractures back into this region.
Radial head fractures are incredibly common after falling on an outstretched hand, and they frequently come with ligament injuries, especially the LCL complex. Distal humerus fractures, on the other hand, involve the joint surface and almost always require anatomical reconstruction. And whenever you see an elbow fracture dislocation, three principles guide the treatment. Restore alignment, fix what's broken, and start early motion, because the elbow stiffens faster than almost any joint.
Alright, moving down the upper limb, the wrist looks small, but it's one of the most complicated joints we deal with. And the first structure that absolutely loves to misbehave is the scapholunate ligament.
This little ligament connects the scaphoid and lunate, two bones that are supposed to move as a team. When it tears, that teamwork disappears. The scaphoid flexes, the lunate extends, and the wrist suddenly becomes unstable in ways the patient can't explain but definitely feels.
So, what does the instability look like in real life?
They'll tell you about pain on the back of the wrist, especially when they grip something or push up from a chair. Sometimes they mention a click or catch. That's the scaphoid and lunate drifting out of sync.
And if that problem goes on long enough, the wrist wears out.
Exactly. Over time, the abnormal motion grinds down the joint surfaces, leading to a specific pattern of arthritis called scapholunate advanced collapse. Basically, the wrist saying, I've held it together long enough.
Next stop, The distal radioulnar joint, or DRUJ, the reason you can turn a doorknob or rotate a key.
This joint is all about pronation and supination, the radius rolling around the ulna. When the DRUJ becomes unstable, people often describe pain on the ulnar side of the wrist and trouble rotating the forearm. Some even say it feels like the wrist is slipping or not trustworthy.
And visually, what clues you in?
On the lateral view, you may see the ulna shifted slightly forward or backward compared to the radius. It's subtle, but that subtle shift matches exactly how the patient feels, like something just isn't lining up.
Now, the celebrity of the ulnar side, the triangular fibrocartilage complex, the TFCC.
This structure is the wrist's shock absorber and stabilizer on the ulnar side. It's a mix of cartilage and ligaments that hold the distal ulna and carpal bones in harmony. When it's injured, patients point right to the ulnar side and say, "It hurts here when I rotate my wrist or push on it."
Like a gymnast pushing off the floor or someone trying to twist open a tight jar.
Exactly. Twisting, load bearing, or falling on an extended wrist can tear it. And here's the tricky part. X-rays can look perfectly normal, but the patient knows something is off. They may feel clicking, weakness, or sharp pain with rotation. That's classic TFCC behavior.
Let's talk fractures, starting with the most common, distal radius fractures.
These happen in all age groups and can be stable or unstable. A stable fracture with good alignment typically just needs a cast, but if the alignment is off, especially if the joint surface is involved, that's when surgical fixation becomes necessary.
And then there's the scaphoid. Tiny bone, but big consequences.
The scaphoid gets most of its blood supply from the distal end, so a fracture through the center or wrist can cut off blood supply to the proximal pole. That's why a scaphoid fracture can lead to avascular necrosis. So if someone falls on an outstretched hand and has tenderness in the anatomical snuff box, even with a normal X-ray, you take it seriously.
So the wrist is basically a magician. It can hide serious injuries behind normal X-rays and tiny complaints.
You're absolutely correct. If the pain is on the back of the wrist, think scapholinate ligament. If the pain is with rotation, think DRUJ or TFCC. If the pain is snuff box tenderness, think scaphoid. And if the alignment of distal radius fracture looks off, that's your cue to stabilize it properly.
Alright, shifting gears into the hip. A deep, stable ball and socket joint that somehow still manages to cause an enormous amount of pain in athletes. Let's start inside the joint, the labrum.
The labrum is a ring of fibrocartilage that lines the rim of the acetabulum. Its job is to deepen the socket, create a suctional seal, and keep the femoral head centered. So when it tears, the joint loses that smooth containment. Movement becomes painful, especially those involving rotation.
And how do these tears usually happen?
There are two classical pathways. One is structural impingement. The femur or acetabulum has extra bone, so they bump into each other. The femoral bump is called a cam shape. Extra coverage on the acetabulum is a pincer shape. With repeating hip flexion and rotation, these shapes press against the labrum and eventually tear it. The second pathway is sport-related. Dancers, football players, gymnasts, basically anyone who lives in deep flexion and rotation.
And the symptoms always sound the same.
Groin pain, clicking, catching, or the sense that something in the hip is mechanically stuck. If rotating the hip triggers the pain, that's a big clue the problem is intra-articular.
Now let's move outside the joint. Because half the people who say, "My hip hurts," don't have a joint problem at all.
Yeah, one of the biggest culprits is the iliopsoas tendon, the main hip flexor. Overuse, tightness, or imbalance can irritate it.
And the patient points where?
To the front of the hip or groin. They'll say it hurts when they get up from sitting, climb stairs, or lift the leg. Some even describe a subtle click or snap. That's the iliopsoas tendon flicking across the front of the pelvis.
So, anterior hip pain plus snapping sensation? That's your iliopsoas tendon making itself known.
That's right.
And what about pain on the outer side of the hip?
That's almost always gluteal tendinopathy, especially involving the gluteus medius. People often blame the iliotibial band, but the real issue is the tendon where it inserts near the greater trochanter.
And the giveaway symptom?
It hurts when I lie on that side. Patients always complain of pain with single leg stance or when they climb stairs. It's soft tissue overload problem, not a joint problem.
Now, the snapping hip, the one everyone likes to demonstrate dramatically.
Right. Snapping hip comes in two flavors. Internal snapping, from the iliopsoas tendon snapping over the femoral head or pelvic ridge. The snap is felt in the front. External snapping, from the iliotibial band or gluteal maximus snapping over the greater trochanter. This one is lateral and sometimes you can see it.
So, clicking hip doesn't automatically mean the labrum?
Correct. Location matters. Front equals iliopsoas. Side equals iliotibial band or gluteus maximus. Inside the joint equals labrum.
Another common source of hip region pain, bursitis.
Two main bursae matter clinically. Trochanter bursitis causes lateral hip pain, worse with lying on the affected side, often sits hand in hand with gluteal tendinopathy. Iliopsoas bursitis causes anterior hip pain, worse with hip flexion, sometimes associated with snapping.
And again, none of these involve the actual hip joint. But the patient will still swear it's the hip. Now let's talk about a high stakes condition, avascular necrosis.
Avascular necrosis is when the blood supply to the femoral head is disrupted, leading to gradual collapse of the bone. The pain is deep, usually in the groin or buttock, and it gets worse with weight bearing. Early on, X-ray can look normal, which is why the diagnosis is often delayed.
And who usually gets this?
Those with prior femoral neck trauma, and those with certain systemic risk factors like steroid exposure or chronic alcohol use. If untreated, the femoral head collapses and arthritis develops, eventually requiring joint replacement.
So, if we had to simplify hip pain into a quick mental map,
It goes like this. Groin pain plus catching or clicking, think labrum or intra-articular problem. Anterior pain plus snapping, think iliopsoas tendon. Lateral pain plus can't lie on that side, think gluteal tendinopathy or trochanter bursitis. Deep aching pain with weight bearing, consider avascular necrosis.
and just like that, the hip, one of the most confusing regions in MSK, starts making sense. Alright, moving down to the knee. A joint that somehow manages to be strong enough for sprinting, but fragile enough to get injured by twisting wrong. Let's start with the meniscus.
The menisci are two C-shaped shock absorbers that deepen the joint surface and distribute load. When someone twists on a planted foot, like pivoting or squatting down awkwardly, the meniscus can tear.
And the story tends to write itself.
That's right. So for meniscus tears, you might see a click or catch during movement, pain along the joint line, and sometimes the knee gets stuck. That's a locking episode. When you bend and rotate the knee, that torn flap can literally get trapped between the femur and tibia, causing that sudden stuck feeling.
So, clicking plus locking plus joint line tenderness, that's classic meniscus territory. Now, onto something people underestimate until they learn it once: OCD. And no, not the personality kind.
Right. This one is osteochondritis dissecans. It's when a patch of bone just under the cartilage loses its blood supply. When that happens, the bone weakens and the cartilage sitting on top can start to loosen or separate, almost like a tile peeling off a wall.
And who gets this?
Usually young athletes, football, basketball players, and gymnasts, anyone with repetitive impact. They come in saying, "My knee feels deep and achy after activity," or "It swells after sports." If the fragment becomes unstable, then you start getting clicking or locking, similar to a meniscal tear.
So, deep activity related knee pain in a teenager, OCD should be on your radar.
Exactly. And the most common spot is the lateral side of the medial femoral condyle.
And now, the superstar of vague knee pain, patellofemoral pain syndrome.
PFPS is a classical cause of pain around or behind the kneecap. It isn't a tear or a loose body, it's simply irritation from the patella not gliding perfectly in the groove.
So, the pain shows up when?
Walking up the stairs, squatting, sitting for long periods, anything that increases pressure between the patella and the femur. People describe it as a dull ache rather than a sharp pain. One physical clue is the J sign, where the patella jumps or tracks laterally during extension.
Right. PFPS is a movement problem, not a structural failure. Let's talk tendons, because knee tendons take a beating.
We'll start with the patellar tendinopathy. This one affects the tendon below the kneecap. Repetitive jumping or overload irritates it. Pain sits right at the inferior pole of the patella and flares when you jump, squat, or extend the knee against resistance.
And importantly, no locking, no instability, just localized anterior pain.
And now on to quadriceps tendinopathy. It affects the tendon above the patella. It's more common in older athletes or anyone doing repeated kicking or acceleration.
But when the tendon actually ruptures,
Then it's unmistakable. A complete rupture means the person cannot actively extend the knee. They might describe a sudden sharp pain or a popping sensation, but the key is they cannot straighten the leg.
and the patellar tendon behaves the same way if it ruptures?
Precisely, if the patellar tendon tears, knee extension disappears because the entire extensor mechanism is broken. So sudden injury plus inability to extend equals tendon rupture until proven otherwise.
Let's hit another extremely common sports injury: hamstrings.
Happens during sprinting, especially that moment where the muscle is contracting while being stretched, an eccentric load. Patients describe a sudden sharp pain in the back of the thigh, sometimes with bruising. Most are strains and heal with rehab.
And the serious version?
A hamstring avulsion, when the entire origin tears off the ischial tuberosity. That needs surgery because the muscle can't function when completely detached.
And last in our knee section is patellar dislocation.
This one shows up in young athletes, especially females, during a twist or valgus movement. The kneecap slips laterally out of its groove. There's usually a sudden giveaway, swelling from the blood in the joint, and a lot of anxiety.
And what's the key exam finding?
The patellar apprehension test. Gently push the kneecap laterally and the patient tightens up because they recognize the instability. MRI is important after a first-time dislocation to look for two things: injury to the medial patellofemoral ligament, the main stabilizer, and any cartilage or bone fragments that sheared off.
Once it happens, the risk of recurrence goes up.
Very well said.
So, how do we keep all these straight?
Think of it like this. Clicking or locking means there's a problem in the meniscus. Deep ache in young athletes is a sign of OCD. Vague anterior knee pain, think of patellofemoral pain. Pain above or below the patella, think of quadriceps or patellar tendinopathy. Sudden inability to extend is a sign of tendon rupture. And finally, if the kneecap slips laterally, that's patellar instability.
Beautiful. The entire knee in one structured snapshot. Okay, knee is done. Let's move down into the foot and the ankle. This is where biomechanics really matter. And it's where injuries can look mild on the surface, but carry really high stakes underneath.
The Achilles tendon is the strongest tendon in the body, but ironically, one of the most commonly ruptured. It almost always happens at the exact moment of push-off. In tennis, basketball, running, especially in what we love calling weekend warriors, people who go hard despite not training consistently.
And the way they describe it, it is always the same.
Yep. Patients say it felt like someone kicked them from behind, followed by a sudden pop. After that, pushing off becomes nearly impossible. The Thompson test is key here. If you squeeze the calf and the foot doesn't move, that means the Achilles is torn.
And treatment?
You can treat non-operatively with functional bracing, but active patients, especially athletes, often go for surgery to reduce the risk of re-rupture.
Moving on, plantar fasciitis might honestly be the most common foot complaint overall.
It's irritation and micro-tearing of the plantar fascia, the thick band under the foot that supports your arc. The signature story never changes. Pain is the worst with the first steps in the morning. It feels like stepping on knives. The pain sits at the heel, especially at the medial calcaneal tubercle. It gradually improves as they move, because the fascia warms up and stretches.
So the first step pain is basically diagnostic.
Exactly.
Now let's talk about less frank injuries. The ultimate, easy to miss, disastrous if you do, injury.
The Lisfranc joint is the tarsometatarsal complex, the meeting point between the forefoot and the midfoot. It's held together by strong ligaments, and when those fail, the entire midfoot becomes unstable. It usually happens either from twisting on a plantar flex foot or a heavy axial load, like falling off a step or foot trapped while twisting.
And the patients don't always come in screaming.
Yeah. They'll have midfoot pain, difficulty bearing weight, and swelling on top of the foot. The biggest clinical red flag is plantar bruising. Bruising under the arch almost screams, Lisfranc! Non-weight bearing x-rays can look normal, so weight bearing films or CT are often needed.
And if you miss it,
Midfoot collapse and arthritis. Unstable ones almost always need fixation.
next, stress fractures, the sneaky ones.
These come from repetitive loading faster than the bone can remodel. Very common in new recruits, runners, and dancers. The classic sites? Second and third metatarsals, the march fractures, but also the base of the fifth metatarsal and the navicular. Pain is gradual, activity related, and very localized. Early x-rays are often normal. MRI is more sensitive.
So, gradual dorsal foot pain plus normal x-ray. Think stress fracture. Next up is ankle impingement. Something that confused me until I realized it's literally just pinching.
Exactly. Anterior impingement hurts at the front of the ankle during dorsiflexion. Think repeated kicking or pushing the ankle forward. Posterior impingement hurts during plantar flexion, like a ballet dancer going en pente, sometimes because of an accessory bone called os trigonum.
So, the pattern is basically pain at the end of the movement.
Ding ding ding!
Let's talk about posterior tibial tendon dysfunction, a surprisingly common cause of acquired flat foot.
The posterior tendon supports the medial arch. When it degenerates, the arch collapses, so this tends to show up in middle-aged women with risk factors like obesity, hypertension, diabetes, or chronic overuse. Symptoms include medial ankle pain, flattening of the arch, and difficulty inverting the foot. The classic clue is the too many toes sign, when you look from behind and can see more toes than usual peeking out laterally.
So, collapsed arch plus medial ankle pain plus too many toes sign equals posterior tibial tendon dysfunction. Before we leave the ankle, there's one more structure that deserves some attention: the peroneal tendons.
They run just behind the lateral malleolus and stabilize the ankle from the outside. They get irritated with side-to-side motion, repetitive inversion, or after ankle sprains. Patients describe lateral ankle pain sometimes with clicking or popping because the tendon is slipping or subluxing from the groove. Pain worsens with resisted eversion.
So, lateral ankle pain with clicking, don't forget peroneal tendon issues.
Here's the quick way to remember everything down here. A sudden pop and weak push-off, think Achilles rupture. Heel pain that's worst with first steps, think plantar fasciitis. Midfoot pain with plantar bruising, think Lisfranc injury. Gradual dorsal foot pain with normal x-ray, think stress fracture. Pain at extreme dorsiflexion or plantar flexion, ankle impingement. Collapsed arch with too many toes sign, think posterior tibial tendon dysfunction. Lateral ankle clicking after a sprain, think peroneal tendon subluxation.
These patterns honestly carry you through half of lower limb MSK. Alright, before we move on to nerves, we need to talk about something every MSK clinic hears 100 times a day. My bone hurts. The tricky part, most of the time, it's not actually the bone.
When someone complains of bone pain, it could be the soft tissue, the joint, referred pain, or an actual bone problem. And each category behaves differently. So the first step is figuring out what type of pain you're dealing with, because the differential completely changes depending on the pattern.
Let's start with the easiest and honestly the most important division: mechanical versus inflammatory.
Mechanical pain is the kind that shows up with activity. Walking, standing, lifting. It aggravates the pain. Rest feels good. Morning stiffness is brief, under half an hour. You will see this pattern in overuse injuries, tendinopathy, osteoarthritis, degenerative spine problems, even stress fractures early on.
And inflammatory pain?
That's the exact opposite. Rest hurts more than activity. Morning stiffness lasts longer, sometimes an hour or more. Symptoms are worse at night. This can be autoimmune arthritis, a systemic inflammatory condition, or even infection.
So the behavior of the pain already tells you which category you're dealing with. Now let's go through the big danger signs, the ones that should make you pause.
First red flag: night pain. Pain that wakes someone from sleep, raises concern for infection or malignancy. Stress fractures can also do this once they worsen.
Second one,
Fever or systemic symptoms. The shift that shifts your mind towards septic arthritis, osteomyelitis, or a significant inflammatory condition.
third, and probably the most intuitive, trauma plus inability to bear weight.
Right. That should make you think fracture or compartment syndrome. Then we have neurologic deficits, numbness, tingling, weakness, which suggests nerve involvement or even spinal cord pathology.
And a really important one, unexplained weight loss.
Yeah, that pushes tumors or systemic illnesses much higher on your list. And in kids, bone pain is never something to brush off. Leukemia, infection, scaphy, juvenile arthritis all need to be considered.
One thing that surprised me when I learned MSK was how often pain is actually coming from somewhere completely different.
It's wild. Hip problems commonly present as knee pain. Lumbar nerve irritation can show up as thigh or calf pain. SI joint issues can mimic hamstring pain. Even shoulder pain can come from the neck.
So, a normal x ray at the site of pain doesn't rule out a significant issue. It might just mean the source is somewhere else.
That's right. Always widen your search if things don't add up.
Let's break down bone pain specifically, because the pattern really helps narrow down the cause.
First, localized point tenderness. That's where you push on one exact spot and the patient jumps. This can mean fracture, stress fracture, infection localized to the bone, or a bone lesion. Even tendon insertion pain can behave like this. Second, diffuse aching pain. This is the vague, widespread discomfort. You see it in many metabolic bone issues like vitamin D deficiencies, generalized osteoporosis, or systemic problems. Kids with leukemia often describe diffuse bone pain as well.
Third, stress fractures. These deserve their own lane.
They're caused by repetitive load that exceeds the bone's ability to remodel. The pain starts only with the activity, then progresses to pain at rest or even at night. You almost always get point tenderness, and early x-rays can be completely normal. MRI picks them up better.
And the usual suspect?
Tibia, metatarsals, femoral neck, navicular, fibula, pelvis, especially in runners, dancers, and military recruits.
Now let's zoom into joint pain, arthralgia, because joints have their own characteristic patterns.
Joint pain can come from inflammation, trauma, cartilage damage, ligaments, injuries, or infection. The way it presents tells you a lot. Acute monoarthritis. So that's one joint. Joint becomes suddenly very painful. You think infection, gout, trauma, or hemiarthrosis. Polyarthritis. So multiple joints become painful at once. Think viral illness, autoimmune arthritis, or systemic inflammatory disease. Intermittent pain with locking. This is mechanical. Meniscal tear or loose bodies inside the joint causes this classical catching or locking. Giving way or instability, that's ligament territory. ACL, patellar instability, chronic ankle instability.
Let's make this really clear. How do you actually tell bone pain from joint pain?
Bone pain is usually very focal, especially when you palpate. It's heavily weight-bearing dependent. Joint pain tenderness comes with swelling, effusion, stiffness, and mechanical symptoms like clicking or locking. Inflammatory joint pain has morning stiffness. Bone pain doesn't, unless it's systemic.
So the exam basically solves half the puzzle. Children deserve special mention because their differentials are a little more dramatic.
Right. Leukemia is one of the most important to never miss. Instead of a sharp, localized pain, kids often come in with vague, widespread bone pain, a limp, or even refusing to walk. They may also show signs of bone marrow failure, fatigue, pallor, bruising, or recurrent infections because the marrow is replaced by blasts. In osteomyelitis, on the other hand, these children look sicker. They present with fever, irritability, and refusal to bear weight on the affected limb. The pain is focal and sharp, and they guard that area aggressively. Then you have scaphe, which is slipped capital femoral epiphysis, classic in overweight adolescent. Even though the problem is in the hip, kids often complain of knee pain because hip pathology frequently refers pain down to the thigh. The hallmark presentation is a teen who limps, with pain made worse by activity. Another common dilemma is transient synovitis versus septic arthritis. Both cause a limp and hip pain, but septic arthritis is an emergency. We use the Kocher criteria, which includes fever, inability to bear weight, elevated ESR, elevated WBC, to decide how likely infection is. And in active kids, pain over the tibial tubercle is usually Osgood Shatter disease, an overuse injury where the patellar tendon pulls on the growth plate.
During growth spurts, the growth plate at the tibial tubercle is still soft and not fully solid bone. When a child or teen does repetitive movements, the patellar tendon repeatedly pulls on the soft growth plate. This constant pulling causes irritation and inflammation. This makes the tibial tubercle tender, swollen, and painful, especially with running, jumping, or kneeling. Adults don't get Osgood Schlatter since their growth plates are closed. Hence, they're now solid bone.
Precisely. And finally, younger boys with gradual hip pain, stiffness, and a limp may have Perthes disease, which is avascular necrosis of the femoral head.
So age plus location is everything.
At the end of the day, understanding the pain isn't enough. You match it with function. What triggers it? What relieves it? How does it affect movement? Is there weakness, locking, instability, or swelling? Does palpation reproduce it? Putting pain and function together is what tells you whether you're dealing with a tendon problem, ligament issue, fracture, stress injury, arthralgia, infection, or something systemic.
And with that framework, you actually start to understand MSK complaints instead of memorizing them. Alright, we've talked bones, joints, ligaments. Now we're stepping into a completely different world. The land of tingling, burning pain, weird weakness patterns, wrist drop, foot drop, all the dramatic stuff.
Exactly. Bone pain is usually predictable. Nerve pain? Never subtle. When nerves get irritated or injured, you get this mix of electric pain, numbness, weakness, and sometimes even classic deformities. So today, we're going to break down nerve injuries in a way that actually makes sense clinically.
Let's start at the beginning, the basic classification of nerve injuries. Because not all nerve injuries are created equal.
Right. There are three main categories. Neuropraxia, the mild one. It's a temporary block. The myelin is irritated, but the axon is intact. You'll see weakness or numbness after compression, but recovery is full and usually quick. Axonotmesis, the middle one. Here the axon is damaged, but the surrounding structures are still intact. The body has to regenerate the axon, so recovery takes weeks to months. Neurotmesis, the severe one. This is a full cut of the nerve. There is no spontaneous recovery. It needs surgical repair.
So the big clue is really the mechanism and how long the weakness lasts. And then there's the more detailed classification, Sunderland's.
Think of Sunderland as just expanding Sidon. Grade 1 behaves like neuropraxia. Grade 2 behaves like axonotmesis. Grade 3, 4, and 5 are progressively worse damage to the connective tissue layers around the nerve. Grade 5 is a complete transection, so the more disrupted the architecture, the less likely the nerve is to heal on its own.
Good, so we're not memorizing details, just understanding severity. The next thing that confuses people is the nerve exam. They try to memorize every muscle a nerve innervates.
But the trick is simpler. Instead of memorizing muscles, think of what movement is weak and what area is numb. Each nerve has signature patterns, and once you recognize them, it becomes logical instead of overwhelming. Radial nerve gets injured with humeral shaft fractures or prolonged compression. The hallmark is wrist drop. The patient can't extend the wrist or fingers. Sensation is reduced over dorsum of the hand, especially the first web space.
So if someone can't extend their wrist after a humeral fracture, that's your answer.
Median nerve is compressed in the wrist or injured around the elbow. You'll see weakness in thumb opposition and difficulty flexing the index and middle fingers into a fist. Sensation is affected in the thumb, index, middle, and half of the ring finger.
So the classic picture is numbness in the lateral fingers and thenar muscle wasting.
Ulnar nerve, you lose finger abduction and adduction, the interossei become weak, and you can see an ulnar claw appearance. Sensation drops in the little finger and half of the ring finger.
And that's why the hand looks weak and clumsy.
Common peroneal nerve. This nerve wraps around the fibular neck, so it's vulnerable to compression or fractures there. The hallmark is foot drop, loss of dorsiflexion, and decreased sensation over the lateral leg and dorsum of the foot. Tibial nerve. If this nerve is injured, the patient can't plantar flex. They can't stand on tiptoes. Sensation is lost on the sole of the foot. Femoral nerve. You'll see troubles with knee extension and difficulty climbing stairs. Sensation is reduced in the anterior thigh and medial leg. Obturator nerve controls thigh adduction, so injury means difficulty bringing the legs together and reduced sensation on the medial thigh.
Perfect. Those lower limb patterns make so much more sense when you frame them by movement. And now, the big one. The emergency that everyone needs to recognize immediately. Compartment syndrome.
Right. This is when pressure inside a closed muscle compartment rises so much that it cuts off blood flow and compresses nerves. The most important early warnings are pain out of proportion and pain with passive stretch. Everything else, pallor, pulselessness, paralysis, comes later.
And the causes?
Tibial fractures, crush injuries, very tight casts, or reperfusion after ischemia. But regardless of the cause, the treatment is always the same, an urgent fasciotomy to save the muscle and nerve.
Before we wrap up, let's touch on muscle injuries.
Hamstring strains are extremely common in sports. Sudden posterior thigh pain during sprinting. Quadricep strains show up as an anterior thigh pain, usually with sprinting or kicking. Gastrocnemius strain, often called tennis leg, causes sharp pain and difficulty pushing off. Partial tears can be rehabbed, but complete ruptures often require surgical repair.
So, how do you distinguish nerve pain from typical MSK pain?
Nerve pain feels burning or electric and follows a dermatomal pattern. It worsens when the nerve is stretched, and you'll often find numbness, tingling, or reflex changes. Musculoskeletal pain feels more mechanical, achy, localized, triggered by movements or load.
And that brings us to the single rule every trauma exam and every real-life trauma consult lives by.
Always test nerve function in fractures and dislocations, especially around humerus, elbow, knee dislocations, fibular neck, and ankle injuries. A fracture can wait, nerve ischemia cannot.
Nerves are dramatic. They complain loudly, and ignoring them is how you end up with permanent deficits.
Whoa, that was a lot. How would anyone remember all this information?
To put everything together, let me give you a few cases.
Alright, sounds good.
Alright, picture this. A 19-year-old football player pivots to change direction. She suddenly hears a pop, goes down, and within minutes her knee is massively swollen. She can't bear weight at all.
That combination, pop, immediate swelling, non-contact pivot, fits perfectly with an ACL tear. The swelling comes from a hemarthrosis, which makes the knee stiff and painful to examine.
So, what's the first step? MRI or straight to the OR?
Neither. When the knee is acutely swollen and locked up, rushing into reconstruction risks long-term stiffness. The first priority is to calm everything down, control swelling, and restore basic range of motion. Once the knee moves comfortably again, then reconstruction can be planned if needed.
And early on, if the drawer test is hard to interpret because they're guarding,
You rely more on Lachman. It's most reliable when the knee is swollen or painful.
next case. A 24-year-old gymnast falls on an outstretched hand. X-ray, completely normal. But she points out to pain on the ulnar side of the wrist and says it hurts when she twists her forearm or pushes off a table.
That's a classical setup for a TFCC injury. The triangular fibrocartilage complex stabilizes the distal radioulnar joint. so anything involving twisting or load through the wrist irritates it.
Right. So normal x-ray doesn't mean the wrist is fine.
Yep. When the pain localizes to the ulnar side, especially with rotation or push-off, TFCC injury jumps to the top of that list.
Moving on to the next one. Okay, imagine a 32-year-old man with a closed tibial shaft fracture after a fall. His pulses are intact, but he's yelling that the pain is unbearable. You gently dorsiflex his toes, and he screams.
That's a danger zone. Compartment syndrome. Pain out of proportion and pain with passive stretch are the earliest and most important signs. The pulse can still be normal, so you can't rely on them. Immediate fasciotomy. You don't watch it. You don't order imaging. You decompress right away.
Next case. A 33-year-old man comes in with a midshaft humerus fracture after a motorcycle crash. On exam, he can't extend his wrist.
That's a radial nerve palsy. The nerve wraps around the humerus, so fractures in that region can stun it.
And do we panic and rush into surgery?
Not usually. Most of these injuries are neuroparaxias and recover on their own over weeks. The exception is that if it happened with an open wound or penetrating injury, then the nerve may need direct exploration.
Here's one for the ankle crowd. A 28-year-old basketball player lands awkwardly. His ankle is swollen laterally. You perform the Taylor tilt test and it opens up.
The Taylor tilt stresses the calcanefibular ligament, the CFL. So if that test opens, the CFL is injured.
Good. And if the mechanism involved inversion with plantar flexion?
That will point more towards the ATFL as the commonly injured structure.
Alright, Beshr, you did great so far. But let's really test your knowledge with the lightning round, where we'll recall the big concepts. After a hip replacement, which post-operative issue is the least critical compared to others? Pain control, mobility, walking early, or preventing infection?
Pain control matters, but it's not top priority. Infection and mobility are far more crucial because they directly affect survival and function.
17-year-old steps off a curb and fractures her femur. What's the concern?
That's suspicious for a pathological fracture. A healthy femur shouldn't break from such a minimal force.
Knee pain with locking, clicking, and pain on rotation. What's going on?
That's a meniscal tear. Locking comes from the torn flap getting caught.
Which fracture carries a high risk of compartment syndrome?
Tibial plateau fractures. They bleed into multiple compartments.
Next, patient can't supinate or pronate after wrist trauma, and the distal ulna sits dorsally on the lateral x-ray. What's injured?
The distal radioulnar joint. The dorsal positioning tells the story.
Numbness in the first web space of the hand. Who's the culprit?
The radial nerve, specifically its superficial sensory branch.
Pain above the ankle joint worsened by squeezing the tibia and fibula together. What's injured?
The syndesmosis, the high ankle ligament complex. And that's a wrap on MSK trauma, joints, and neuromuscular injuries. If you made it this far, your future patient with a swollen knee, a sprained ankle, or a mysteriously numb hand will definitely thank you.
Thank you all so much for tuning into PodBites. We hoped we managed to make the wild world of sports medicine a little less intimidating. Good luck on your exams. Break a leg. I mean, not literally. Please leave your skeleton intact. Bye everyone. Catch you in the next episode.
Bye.
بسأل يا حبيبي بسأل
يعني ايش يعني
لا ما قلتش كده قلت يعني هي arc different ولا لا
صراحة it sounds like a child complaining. Pain is the worst. يعني مالها
My feelings my يعني وقفت على خلاص آخر paragraph بلشنا نخبص